we've shown that the nasal breathing is very important to restore good nasal breathing in order to help treat sleep apnea. And avoiding mouth breathing is important. In the immortal words of George Catlin, if you want good health, shut your mouth.
Hi, everyone, and welcome to Vital Discourse. This week, we're going to talk about obstructive sleep apnea and nasal obstruction. So decreased breathing through your nose. How does that affect obstructive sleep apnea? Does it affect obstructive sleep apnea? So I'm here with Dr. Ben as usual. Dr. Ben, take it away. Give us brief discussion about what sleep apnea is, just so that people kind of get that. I know we've had a couple of episodes on it before. And then let's get into why nasal obstruction might have an effect on it.
So as we know, sleep apnea is a progressive weakening of the structures of the throat, namely the palate and tongue, usually mixed with the nasal obstruction. It's based on the idea of the Starling resistor, kind of a technical description. We like to talk about it in your mind's eye about like a paper straw that you put in your Sprite, and you go take a sip on it. It works fine. About 15 minutes later, the structure of that straw has changed over time, and you go to suck on it again and it collapses. That's the general idea behind fluid moving through a collapsible tube. Well, today we're going to talk about how that's affected. We think of the nose in that model as the upstream resistor. So it controls how that fluid, air, flows through this collapsible tube, and it's very important. If you have a relative nasal obstruction, that means these are going to be some terms that I think are familiar to some people, but not everybody, so we'll explain them a little more. But let's say that your nose is slightly narrowed. Air has to speed up to go through there to get down into your lungs to keep the volume the same. You got to have the same amount of air getting into your lungs so that you stay oxygenated. Well, when it's narrowed and it speeds up, that represents a negative pressure suction down the throat. When you have a negative pressure inside a collapsible tube, you're going to tend to collapse. So that is all a progressive narrowing of that nose all the way up into and including full mouth breathing, in other words, full nasal obstruction. So anything on that curve is going to severely affect the severity of sleep apnea.
So I look at it this way. So if you are trying to suck in through a big straw, the air comes in really, really easily. When you try and suck in through a small straw, what happens? Your cheeks collapse, right? Because you're trying to suck in. Well, that's kind of the relationship if the straw is the nose and our cheeks represent the walls of the throat. That's kind of what happens. So if you're trying to pull in air through a narrow nasal cavity, it doesn't have to be completely obstructed. It doesn't have to be that you can't breathe it all through your nose. It could be simply that when you lay down at night, the lining of the nose swells and you get some nasal airflow increased resistance or turbulence. That will be potentially enough that it'll cause your cheeks to collapse in, right? And that's your throat collapsing in and closing off your airway, which is basically what sleep apnea is. You're trying to breathe, but you can't because something is obstructing the airflow, right? So we both have people that come into our office and they've tried oral appliances and whatnot, and they said, no, it didn't work. And then we start talking about the nose, and the answer is, I don't have any problems breathing through my nose.
They'll say that even when they're mouth breathing.
Tell us why that's actually really not the case.
Well, so, I mean, a lot of people have had these nasal obstructions because of the way the nose forms. They've had this nasal obstruction their whole life. Some of them are extremely severe, but it's hard to really know how your experience compares to other people's. You know when you're breathing well, and you know when you're not breathing well. But how does that compare to the way the rest of the population breathes? So it's very difficult sometimes to assess a long-standing nasal obstruction objectively when you're the person it's happening to.
Yeah, and I think that we really don't understand as individuals, how nasal obstruction, for example, when we are children, affects our facial development and our structure, and how that can end up leading to adult obstructive sleep apnea. So probably the greatest risk for adult obstructive sleep apnea is lack of nasal breathing as a kid. And if you talk to any orthodontist, they'll be the first ones to tell you, if you don't correct the nasal obstruction in a kid, they can do all the orthodontical work they want. It's not going to hold.
Yeah, that you get what's called adenoid facies. You get a very particular look to the face. And we've actually, as humans, we've known this for thousands of years. I mean, there's a lot of evidence in Indian literature. Sushruta, who was known for other things surgically, but was known for looking at nasal airway, Ayurvedic medicine. Even as recently as the 1800s in the U.S., George Catlin wrote the book The Breath of Life, where he basically went out and lived with Native American cultures for 20 years. He lived with Native American cultures from Canada all the way down to Brazil and looked at all of their life expectancy, what they ate, and how they dealt with mouth breathing. They, as a child, in the Native American cultures, they would position their children on boards, and the mother would sit and watch the child, and if they started to mouth breathe, they would pinch their lips shut and force nasal breathing at a very early age. And because of that, because of their diet, because of eating a lot of meat and developing their jaws, they had very straight piano-like teeth. They had excellent nasal airways. And according to him anyway, their life expectancy was well into the 70s or 80s, all the way throughout the entire Native American culture, where in the cities where, like Boston and New York at the time, the average life expectancy was about 40. So we've always known that mouth breathing is bad. Humans are nasal breathers. Lee, how many times has a patient come in to you and just said, it was almost like an explanation, well, I'm a mouth breather. I've always been a mouth breather, as though that's normal.
Happens all the time. Interesting. One of the first questions I'll ask is, you sleep with your mouth open or closed? About half the time it's, I sleep with my mouth open. Well, that tells you everything you need to know right there. Mouth opens, tongue falls back, we're obstructing. And then you get I don't know, I'm sleeping, right?
Right.
Okay, well, the next question is, do you wake up with a dry mouth? Oh, yeah, my mouth is parched when I wake up.
Bone
Okay,
dry.
well, you're sleeping with your mouth open. And then you have, well, I don't wake up with a dry mouth at all, and I believe I sleep with my mouth open. And then you look at the anatomy, and they're completely obstructed, right? So you know something's going on. You know, at minimum, if their mouth truly is closed the whole time when they're sleeping at night, they're creating such negative pressure within the back of their throat that they're likely completely collapsing. Now, I want to touch on a couple of things here. So the first thing is, there are actually, believe it or not, some studies out there where they experimentally completely occluded the nose in humans and induced sleep apnea just by complete nasal obstruction.
Almost immediately.
Right, but you and I both know that the average person coming into the office, you're not going to cure them of sleep apnea just by fixing their nasal obstruction issue.
Yeah, it's a 3-level problem in general.
Right. So let's get into first of all, into that and what we do gain in terms of benefit when we improve nasal airflow, both the direct effects, as we were saying, on the change in the pressure, but also downstream effects like effects on ability to tolerate CPAP and oral appliances and those types of things. And second, what types of procedures and what types of things are we looking at in terms of correcting when we're talking about the nasal airway?
Yeah, so I mean that's a big topic, really, but you can break it down to this: it's a 3-level problem: the nose, the palate, and the tongue. If you have a pipe that's blocked in 3 areas and you unblock it in 2, you still have a blocked pipe, and it's important to remember. So when I talk to folks, the first thing that I do is get a CT scan and/or a scope to take a look inside the nose. Usually, if they're coming in with no sleep study, I get a sleep study cooking. We're going to find out what's happening to the palate and tongue. Do they have sleep apnea, mild, moderate, severe? But I get the CT scan and take a look objectively. Are there big narrow points here? Is it moderate to severe deviated septum? Is there nasal valve collapse? Are there large turbinates? Are there large adenoids? And I try and maximize the nasal airway. A lot of people are afraid to have nasal surgery, and so they're kind of like Quint at the end of Jaws, where they're sliding down into the jaws of the shark, and they do not want to say anything that's going to get them a nasal surgery. But things have changed, and nasal surgery is actually quite simple, relatively pain-free, and easy to recover from. And so I try to dissuade people's fear of this to open up and talk to me about it so that I can help correct it. Typically, what you're going to see is a deviated septum correction, a septoplasty, a turbinate reduction, something to help with the nasal valves. And we can talk about that because I know you have a great way of doing that, and so do I. They're very different, though. But we want to open that nose up, even if it's just to help them wear a CPAP mask better or use an appliance. But remember, if you're wearing an appliance and it locks your mouth shut, and you don't breathe well through your nose, you're going to struggle. You're going to wind up taking it out. If you put a CPAP mask on your face and it feels like it's suffocating you, typically that means that you have a nasal obstruction. And we want to open that up. There's multiple studies out there that show that if you have a nasal obstruction and you're failing your CPAP mask, if I fix that nasal obstruction, you'll go on to be able to wear it properly. Same thing with the Inspire implant. If I put the Inspire implant in and you're trying to mouth breathe through that, you're gonna have really low outcomes and not really cure yourself well. So it's an adjunct. It's something that we do first. It's something that we take a look at right away, mainly because we're ENT surgeons, but also because we're treating sleep apnea comprehensively.
So a couple of things. So first of all, Dr. Ben just talked about the Inspire implant. We discussed that in a previous episode, but that is an implant that actually stimulates your tongue to move forward when you're sleeping at night, and that's actually been a pretty big advancement in sleep surgery.
They call it stimulation therapy. That's another term you might hear your doctors throwing around. Stimulators to keep the throat open. So yeah,
exactly. So I deal a lot more in oral appliances than I do in simulation therapy. And one of the things that I say to patients to kind of help them understand what's going on is that if you're wearing an oral appliance and I want to get the airflow behind your tongue, right? If you're not breathing well through your nose, then you might start breathing through your mouth, even though you're wearing an oral appliance. Now, wearing an oral appliance, it doesn't mean that you can't get airflow through your mouth. Your lips can open. If you start breathing through your mouth with an oral appliance, what does it do? It sucks your tongue back. Makes it worse instead of better. So I have patients that come that went to the sleep dentist, and the sleep dentist made amazing oral appliance. They did a great job. But they don't tolerate it, or it's actually making it worse instead of better, and that's because their nasal obstruction was never dealt with. The other thing that I see is patients, especially with severe sleep apnea, that are wearing full face masks. Full face masks are not the easiest thing in the world to tolerate. I'll tell you that right now.
Especially the ones that are over the nose.
Right. And so what ends up happening is someone that has nasal obstruction, most of the air when it's being pushed through a full face mask is actually going through the mouth instead of the nose. You require much higher pressures to force air around the tongue than through a nose. And so the pressures go up, the tolerance goes down.
Also, they're terrible to wear. They're just horrible to wear. You feel like you're a fighter pilot. I mean, you can't see anything. It's hard to watch TV. But by the way, just so you know, what he's talking about, a full face mask is anything that goes around the mouth. There are full face masks that go under the nose and lift it up. The ones that go over the nose are the worst. The ones that go under the nose, a little bit better, but still kind of bulky.
Yeah, so I'm particularly talking about the ones that go over the nose and the mouth, the real big full face masks.
Yeah, anything that goes around the mouth is considered full face, even if it goes below the nose. I wear one. I wear an F40. So, but that's because it's a choice, because the one that goes over the nose is just terrible. Then it tends to close the nose more.
And ideally, I find that nasal pillows are the most tolerable. So nasal pillows just got their cushions that go inside the nose, or actually just right at the opening of the nose, and the air goes through that way. So many times we'll be doing nasal procedures to improve the nasal airflow so that we can switch someone from a full face mask, which they don't tolerate, to nasal pillows, which they can tolerate. So a lot of different things that improving nasal airflow and reducing nasal obstruction can help us with in terms of treating sleep apnea, and that's what we're talking about. Those kind of the downstream impact of improving nasal airflow, and you touched on very briefly, but it's very, very important, the idea of nasal valve collapse, which most, even general ear, nose, and throat physicians don't really have a grasp of. Dr. Ben and I are both board-certified facial plastic and reconstructive surgeons, and so we're very, very familiar with not only nasal valve collapse, but how to treat nasal valve collapse. The nasal valve is the area, this kind of soft area right here, right above the nostrils, right about right there, okay? And if you just gently pinch the very top part of your nose like that, and you try and breathe through your nose, you can see it really makes a huge, huge difference in your airflow. So that's one area. There's another area, and a friend of both of ours, Pete Catalano out of Boston, did a great paper on doing a very, very small procedure near where the openings go into the sinuses to improve that airflow. And these days, a lot of times we do those with balloon catheters and that type of thing. And he found a statistically significant improvement in AHI, or apnea-hypopnea index. Basically, sleep apnea got better in just doing that procedure. So there are a lot of different areas in the nose we don't really even understand why it's having such a positive effect. We do know that we need to have a certain amount of resistance, nasal resistance, in order to completely expand our lungs. So when we breathe through our mouth, right? If people breathe through their mouth, they tend to hyperventilate after a period of time. Why is that? Because you can't completely expand your lungs because you're not breathing in against enough resistance. So the small airways.
One of the things
open.
Also to remember, though, Lee, is that most of the nitric oxide produced in the body is produced in the nose. And so that nitric oxide helps expand those little pockets, the alveoli in the edge of the lungs. And if you're breathing through your mouth, you're getting none of it. So you take this huge nitric oxide producer and you take it out of the circuit, and that immediately makes the lungs a little bit less compliant. But you're right. It's also, again, back to the physics of this, where you got to have a little bit of back pressure in order for the lungs to fully expand.
And the point of that is, we'll call this the vital point of the day, right? Is that not all surgeons that do what we do it the same. Not all surgeons that do what we do have the background both in sleep surgery and facial plastic and reconstructive surgery and rhinology, which is the study and the treatment of nasal and sinus disorders, to identify all these little areas that are so necessary to improve the nasal airway to the point where it's actually helping your sleep apnea.
That's a great point. I mean, if you look at the people just inside Houston, where I practice, there's probably about 400 ENTs here. There's only about 30 of us that do sleep with any intensity, and there's only about 5 to 10 of us that do sleep rhinology and facial plastics. And so it's a little bit more rare to have the sort of a critical mass of those things in one individual, one surgeon.
Absolutely. So let's talk a little bit about, just to kind of wrap things up here, what, generally speaking, if I am someone who has sleep apnea that comes to your office and you decide, you know what, you have nasal obstruction, there's a nasal issue here, what can be done to improve it? Do I have to have surgery? Can you treat it medically? What needs to be done? What can you do in order to improve my nasal airway enough that it's going to have positive impact on my sleep apnea?
That's a great question, and I think you ask 10 different surgeons and you'll get 10 different answers to a certain extent. Some of them are pretty reproducible, though. If your septum's crooked, you're going to straighten it. If your turbinates are large, you're going to make them smaller. If you have sinus disease, you want to try and clear up that sinus disease, because inflammation inside the nose. Stuffy nights are bad nights. So if you have inflammation in there, you're going to want to get rid of it. Those things would lead to like a septoplasty. Remember, as doctors, plasty just means to change. Whatever word I tack it to is what I'm changing. So I'm going to change your septum, make it straighter, change your turbinates, turbinoplasty, make them smaller, and then possibly do a minimally invasive procedure called a balloon sinuplasty to open up those sinuses and clean them out. And then you have to subtly make sure that the nose is working afterwards, which means you're going to be checking for the presence of collapse of the outside of the nose from then on. Sometimes it's not so easy. As you know, I wrote a paper on it years ago about how you evaluate someone's nasal valve beforehand. But when you have multiple sources of obstruction in the nose, sometimes the nasal valve collapse only becomes apparent after you've had your septum and your turbinates and your sinuses fixed. So it's an ongoing thing to make sure that, okay, I had surgery, but does that mean my nose is open? And so you're going to want to answer that question yourself and with your doc over time, not necessarily with one catch-all procedure. You agree with that?
Yeah, 100%. And that's really, really important, especially, for example, you have someone that has a severe deviated septum, and that deviated septum is right in this area where that valve is that we were talking about that collapses. And for years, that septum has been pushed up against that piece of cartilage right here. And you straighten the septum. And after you straighten the septum, all of a sudden what happens? That
Collapse.
Cartilage became so weak from being pushed on by the septum all those years that it starts collapsing in. And now you have to go back and deal with that.
Or perhaps it always
valve.
was collapsible, but there was no airflow through there, so you didn't know.
Couldn't tell. Right. Exactly. Now you are, as far as I'm concerned, one of the world's experts in doing complex nasal valve reconstructions. So tell us a little bit about how you go about determining what to do and what you do.
So I always have a real sensitive conversation with people. My 65-year-old VA patients, not so much, because they're down for whatever. They're kind of like, doc, I don't care. Throw cartilage in me, make my nose bigger. That doesn't matter. But most of the people are not like that, and you have to look at what their goals are and how to change that nose to make it better. The things that I do are Latera implants, little tiny implant into the sidewall of the nose that might help stabilize it, or a larger nasal valve reconstruction, which includes rib cartilage, where you carve it and you actually augment the sides. You change the sides and put cartilage in there. Well, that can make your nose wider. Quite often, it's a hard conversation to have, and it's one that we have over time. My idea is to measure twice and cut once. Talk a lot about it, but and try to minimize the impact of making that nose wider, appearance-wise, with functionality. You got to function well. So there are big surgeries that I do. There are little ones that I do. But yours is actually really interesting to me, because I originally thought that if the nasal valve, if the sidewalls of the nose are misplaced, you got to push them out with cartilage. You recently showed me a couple of really cool examples where you went in and just lasered that tissue and got it to shrink up. And I was very impressed with the post-CT that you showed me, where it actually opened up and changed the position without a big surgery. And so that made me a believer. As you know, we've gotten some of the lasers that you use and are attempting to do that as well here, to duplicate what you do there.
Yeah. So my thought process on this was, you and I both, we do pretty significant and sometimes complex rhinoplasty, which is changing the outward appearance of the nose. And we're working on this area really quite significantly. We're doing a lot, right? We're removing tissue, we're rearranging tissue, and the area is a lot more forgiving than one would think, given the fact that the skin overlying it is pretty thin, and if it changes where it is in relation to the rest of the nose by a millimeter, it makes a big difference in the way it looks and sometimes in the way it functions. So my idea was based on what I saw when I was using the laser to do what's called posterior nasal nerve ablation. So posterior nasal nerve ablation, there's a nerve in the back of the nose that's sort of responsible for telling the lining of your nose to produce excess mucus, and we can calm down its function to decrease postnasal drip and things like that. the bottom line is when you use that laser, what you would see is the lining would just start shrinking up, almost like shrink wrap, and just pulling away. And when I saw that, I thought to myself, well, couldn't that work in the nasal valve also? And so I started trying to do it low power just to see what it would do. And I was very impressed with the outcomes. And it got to the point where I realized I could almost carve an opening in the lower lateral cartilage in that sidewall on the inside and create an extra 2-3 millimeters of opening without changing the way the nose looked at all on the outside. With significant improvement in airflow.
What kind of length do you have on that in terms of time? Have you followed them out 2-3 years or just 6-12 months?
I have, and I've found that it's based on the improvement is based on how well you do improving the opening. Okay, so if you improve the opening a little bit, such that there's still some negative pressure being produced because it's not quite open enough, you will potentially get recurrence over time because you're still pulling, even though it's gentle pulling, and over time it'll start getting lax again. Okay, in which case you can always re-laser and it'll go back to where it was. No harm, no foul. But if you are aggressive the first time and get a really nice opening, that will stand the test of time.
Do you think that there's something about the person's genetics that plays into that? I know we all have different types of makeup to our collagen. Do you think is it a little quirky? Does it matter on who you're doing it on?
I think, well, we both know the difference between dynamic nasal collapse and an active nasal collapse. So if we have someone where the sidewalls are just pinched in as we're sitting there looking at it, that's one type of collapse. And then there's someone else who the sidewalls are where they're supposed to be, but every time you breathe in, they collapse.
Yeah, they slap shut. And that's where I think about cartilage. I put cartilage into those quite often.
So those two different phenotypes, if I can use a technical term, those two different types of genetic makeups, so to speak, in the nose will act very differently. In one of those, I'm trying to get that shrinkage and that pulling out. Okay. And in the other, I'm trying to actually carve things out. So one, I want to create more support. The other, I want to carve out a pathway.
The main message, though, and the difference between yours and mine is that yours has very little downtime and very little risk to the patient, whereas once I cut you, I can't uncut you. So where I'm using your method is as a starter. Let's see if this works. And if it doesn't work in you, we can always do the larger reconstruction. And so that's actually helped me in counseling patients. Let's try this little thing first. If you happen to be one of the ones where it works on, you're golden for very little risk. And we can still rescue it with a cartilage reconstruction. The other thing I do is I'm a plastic surgeon. There are folks where we do what's called a tip rhinoplasty. It's not paid for by insurance, but if they want to change the shape of the nose, I can make the base of it wider, change the top of the nose to make it better, and you come out with a more attractive nose than you went in with. So that's always a little bit of a rescue mentally, where you're like, you're trying to convince somebody to make their nose wider, but if they think it's going to look better overall as the outcome, that's not so bad.
And to your point, even just a little tip rotation back will kind of splay that sidewall out for you.
Yeah, it'll lessen the effect of the larger cartilage grafts.
That's fantastic. That's really fantastic stuff. I got to tell you, people out there listening to Dr. Ben Cilento talk about the valve, I personally could sit here for hours. He knows that much. We're all very lucky to be able to hear this. So I think we've had a great podcast today. We've learned a lot of things, and I think our audience now knows a lot more about how the nose affects obstructive sleep apnea. We're so happy that everyone could join us today and listen in, and we can't wait to see you next time on Vital Discourse.
Yeah, thanks for tuning into Vital Discourse. I think that we've shown that the nasal breathing is very important to restore good nasal breathing in order to help treat sleep apnea. And avoiding mouth breathing is important. In the immortal words of George Catlin, if you want good health, shut your mouth.